Thank you so much for coming, and thank you for those of you who are watching live. This is the Falk Symposium. We're delighted that you're all taking part. A few housekeeping things. We want to apologise for the alarm test at 11:30, but otherwise we hope for a seamless day. The way the sessions are going to work are that we'll have 3 speakers for each session, and those speakers will run continuously for about 15 minutes each, and then there'll be a Q&A at the end. So if you're in the audience, please put your hand up and you can ask a question at the end of the 3 speakers, or you can use Slido and we'll look at those questions and bring them through at the end of the first session. So I'm delighted to say hello to you. My name is David Sanders. I work within Sheffield Gastro with my colleagues, many of whom are here today, and my co-chair, who's going to introduce the first speaker, is Marion Sloan, who's our legendary GP with an interest in gastroenterology and current chair of the Primary Care Society for Gastroenterology. Marion.
Thank you, Dave. Thank you. Thank you. I'm really pleased to be here. It's lovely to see so many people, and what a programme we've got lined up today. Gastro is such an important area in primary care, isn't it? 1 in 3 people who come in, they'll have some sort of gastro-related issue. And it's up to us to notice those things. There was a guy on the radio this morning talking about people missing bowel cancer and the massive implications that has down the line. So this is a whole day of interest and ability for us to now hone our skills and get really sharp. It gives me great pleasure to introduce Charlie, who is a phenomenal GP in Bath, who's got special interest in gastroenterology and is absolute live wire, doing stuff all the time, in addition to his general practice work. Part of the Primary Care Society of Gastroenterology is a series of podcasts, and really Charlie is the brainchild for this, and he's done one on celiac disease, which if you've got time to, it's all free, you just dial in and listen. Celiac disease, and also a chat with the professor who is Dr. Professor Helicobacter, really high profile stuff. So Charlie's talking to us this morning. We're very pleased to welcome him to Sheffield. Charlie.
So thank you very much, Marion, for that introduction. Very kind. And thank you, Dr. Falk and David, for inviting me to talk today. You've got a fantastic lineup on the schedule today, and I'm really honoured to have been included in that lineup, actually. So I've been given the topic of setting the scene in gastroenterology from a primary care perspective. Obviously a really big topic, and one could look at primary care and gastroenterology and feel quite depressed about waiting lists and significant disruption from COVID, but I don't really want to start this conference on a really low, sort of depressing note. So what I'd like to do is I'd like to share a vision with you by the end of this short 15-minute talk. A vision and a view that we should be able to view the challenges of COVID and the extending waiting lists not just as a challenge, but actually as an opportunity to innovate and to rethink how we view primary care and gastroenterology services. But first of all, a little bit about me. So I'm a GP, as Marion said, so I work in somewhere called Midsummer Norton near Bath, and that's my main job. But I also spend part of my time working here. So no, I'm not a Butlins entertainer. Part-time, that's actually the swimming pool at the Royal United Hospital in Bath. So after your busy shift, you get to go and have a little swim and relax. But I spend part of my time working as a GP with an extended role in gastroenterology, and I run an outpatient clinic at the local hospital, covering anything from 2 weeks to routine referrals and everything in between. As Marion said, I'm also part of the Primary Care Society for Gastroenterology. And as she also alluded to, I'm a bit of a gastro nerd. I'm a little bit geeky. I really enjoy gastro and I love education as well. And so I have been running the Ingest Podcast. So every 2 weeks I bring out an episode, and it's designed for primary care clinicians. And it's about what do we do with that patient with chronic diarrhea? What do we do when someone comes in with dyspepsia and their endoscopy is normal? So I try and address some of those questions in the podcast. And as Marion said, I spoke to a gastroenterology rock star recently, and no, it wasn't David Sanders, it was someone called Professor, I've forgotten his name, how terrible is that? Barry Marshall, who won a Nobel Prize actually for drinking 2 Petri dishes of H. pylori and infecting himself in order to prove the link between gastritis and H. pylori. So a really interesting discussion there. It didn't go down very well with his wife when he told her that he'd drunk all this H. pylori and made himself sick. But so have a listen. It's great. But I am biased. So firstly, I'm expecting that most people listening to this talk are not gastro nerds like me. I know that I'm a bit unusual and a bit different, but I hope that you'll appreciate that, the reason you're here is because you appreciate how important gastroenterology is within primary care, and that it's a big part of what we do. Either that or you're here because you want to have a day out of clinic, you want a coffee, a bit of a hot food, so one of those reasons, but hopefully you appreciate that it is important. And it's estimated that about 10% of primary care consultations are related to gastrointestinal conditions. And it's not surprising given the wide range of conditions that we see in gastroenterology. It's a huge specialty. You've got benign and functional conditions such as IBS, dyspepsia, and you've got the hepatobiliary conditions, and obviously you've got the hugely important malignant conditions that we must be picking up in primary care. So for example, looking at the top 10 cancers in 2018, you had colorectal cancer number 4. You also had pancreatic and esophageal cancers right up there. So really important specialty when it comes to malignancies. And it looks like the prevalence of gastrointestinal conditions is increasing. So for example, inflammatory bowel disease, prevalence in 2003 was found to be about 0.4%. A recent study from 2019 in Scotland found a prevalence actually nearly double that at 0.78%. So a significant number of patients, and they predicted that the prevalence was going to increase to greater than 1% by 2030. So this is going to take up a larger proportion of our work. And these patients have lifelong conditions, which need lifelong monitoring and support. Celiac disease, so this 1990s Kumar and Clark textbook saying that the prevalence was 1 in 1,500. We now know that 1% of the population has celiac disease, a huge number. Are there environmental factors that are pushing up prevalence? And actually, there's a recent study from Italy that looked at a large number of school children and found that the prevalence was actually probably closer to 1.5%. And we've also got the issue around liver disease. So whilst we've been seeing a decrease in death rates for large numbers of cancers, diabetes, heart attack and stroke, the mortality rate from liver disease has increased by 400% since 1970. And we're facing an epidemic of lifestyle-related liver disease as well, with non-alcoholic fatty liver disease affecting 30% of the population. And a statistic that I find absolutely terrifying and fascinating is that about 1 in 5 of the people with fatty liver disease will progress to develop fibrotic liver disease. So a huge potential problem approaching us in the future. And COVID. Obviously, it's hard to have a talk about the scene in primary care without talking about COVID. So from a clinical point of view, we know that COVID is not a respiratory condition primarily. I've spoken to so many patients who have gastrointestinal symptoms as the primary presenting complaint, so we know that it has a huge impact on the GI tract. But what is potentially more concerning but more interesting is the long-term sequelae. So we know that there are patients who develop longer-term gastrointestinal symptoms from COVID. So a study in The Lancet followed up a number of patients at 90 days after their infection with COVID and found that between 10 and 20% of them had ongoing GI symptoms, primarily GORD, but also nausea and chronic diarrhea. So actually we may be starting to have to think about COVID as part of our workup for patients with chronic diarrhea. But from a non-clinical and more system-based approach, it's had a huge impact on waiting lists, and we know this. So we've got waiting lists for elective care up at 6 million, as you can see, the same size as the population of Denmark. And a really worrying feature from February, the public accounts information showing that the number of people waiting over 12 months has increased from 1,600 pre-COVID to 340,000 patients. So it's a huge increase in the number of patients waiting a significant amount of time for routine outpatient appointments. And this leads to a huge burden in primary care. We have to carry a lot more care for these patients. And this is, having a big impact on our ability to provide service for our patients. And in endoscopy, there was a huge chasm of drop-off of activity at the time of COVID. So a 90% drop in activity at the time that COVID hit. And it really took many, many months to get it back up to 80 to 85%. So by the end of 2020, we were approaching 85% capacity. But this has led to a huge backlog and a huge difficulty getting routine endoscopy services, certainly in my area. And I know that there's a huge amount of work to try to bring endoscopy services back up to pre-pandemic levels. But I think it's going to have a huge impact moving forwards on our ability to carry out endoscopy procedures. And how have we been approaching some of these issues? Well, there's been telemedicine, so we've all seen the growth of telemedicine, primarily in primary care. You know, we've been taking on telephone consults, video consultations, but in gastroenterology, we've also seen the growth of telemedicine. And one example is, for example, the My IBD Care app, where you're remote monitoring patients with IBD, and they've seen a huge drop in the number of outpatient appointments required by allowing patients to self-manage and self-monitor their conditions. And I wonder if we might see home fecal calprotectin testing happening at some point in the future as part of that drive to help support that growing number of patients with IBD in the community. Pathways. So, sorry, that one doesn't come across very well, but essentially we're seeing pathways develop to try to improve and reduce the need for endoscopy. So this is the non-biopsy celiac pathway, where actually a number of patients may not need to have a biopsy in order to make the diagnosis of celiac disease. This helps with capacity and endoscopy. And greater use of pathways such as the fecal calprotectin pathway, differentiating irritable bowel syndrome from inflammatory bowel disease, will help with that as well. And prioritization. So for the first time, in the latest iteration of the network contract DES, released in March 2022, we saw the Impact and Investment Fund putting money into assessing and prioritizing patients being referred via a lower gastrointestinal 2-week wait pathway. So for every patient being referred through, if we do a FIT test, there is money coming with that in order to try and help prioritize which patients need to have, for example, a full colonoscopy, which patients might be more appropriate for a sigmoidoscopy. So to try to prioritize that service. And incidentally, it's the first time that we've really seen funding coming along with gastroenterology and primary care, given that gastroenterology for many, many years has been notably absent from many QOF indicators. But I think we need to really reimagine how we do things. I think that this is the time where we have to think, how are we going to make a difference here? In Formula One, I'm a bit of a Formula One fan, and I love Drive to Survive on Netflix. In Formula One, teamwork and unity of purpose is absolutely vital in order to have a race car going around a track at 200 miles an hour with a human being inside it. These Formula One teams are made up of highly specialized individuals. They work in a highly integrated way, so they all have a particular role, but they all communicate with each other. So the drivers are pivotal when it comes to developing the vehicles. They're test driving the cars. The designers are sitting there on the side of the race. They are tweaking the vehicle at all points. This is a highly integrated team. You know, the wheel nut guy, he knows exactly how he fits into the bigger picture, and without him, the whole system really wouldn't work. But I think that moving forwards, we need to think like a Formula One team when we're considering gastroenterology services, and particularly how we interact and communicate between primary and secondary care. I think we need to think about working in an integrated way and with a unity of purpose, just like a Formula One team. And I think that the primary care landscape is changing to allow this to happen. And I think that's really exciting. So in 2019, PCNs came on board, and we started working at scale amongst GP practices, sharing staff, sharing services. And more recently, we've seen the introduction of the integrated care systems this year. So looking at the integration between primary and secondary care. So the old model of the tiered system that we have of primary care, the patient moving into secondary care and potentially to tertiary care, could potentially be reimagined, okay? Because we know that patients don't move in a linear way. They move through systems and they need care across all systems. So is there an opportunity here to reimagine this and think about a community-based approach? And there are services out there. There are things going on that are really exciting. So in the realm of celiac disease, we know that there are dietitians working in the community providing follow-up for patients. These are fantastic models, and this is Christian Costas in Bradford, who runs one of these services, a really good service for patients. But with the ARRS scheme, so the additional role reimbursement scheme, do we have an opportunity here to do something really interesting? Can we, for example, bring dietitians within PCNs? Can we actually help support our patients with IBS better? Thinking about group consultations and supporting celiacs, could this be a role that could be beneficial to us in PCNs? And then just thinking about how we could move diagnostic services out of the hospital. Is there a role, for example, for teleproctoscopy and teleendoscopy? These things are already done in remote parts of Scotland, so could there be something in that? Thinking about cytosponge for Barrett surveillance, could that be something that could be brought into the community? Or thinking about the growing field of capsule endoscopy, could this be something initiated in primary care? These things can all bring work and bring services out of the hospital and ensure that secondary care see the patients that they need to see. Is this something that could have a huge impact on waiting lists and making sure that the patients see the right person at the right time? And finally, onto the GP with an extended role in gastroenterology. So there's been plenty of examples of GPs working within gastroenterology in the past, in traditional roles such as associate specialists and GP endoscopists. But there's no framework, there's no pathway for GPs to follow. So if you want to do this, you have to find it yourself. In dermatology, we have a well-trodden route and a framework to make this, but in general practice, we don't have that. However, that's changing. I'm in discussions with the BSG to create a framework along these lines where we can take a GP and we can show them the route towards becoming more expert in gastroenterology. And this could be used within trust to help develop this role. And what could this role actually look like? Well, you've obviously got traditional ideas of GP endoscopist, etc., but why don't we do something really different and really interesting and really new? Why don't we have a PCN-based GP with an extended role, looking at referrals, helping to maximize them, linking in with their colleagues within the PCN, building relationships between primary and secondary care, seeing those patients who are coming through that PCN, consulting, and actually being able to do that. That would be so interesting. What about one-stop clinics in the community? What about a GP who consults and is able to then do an endoscopy for disease-specific areas? For example, that huge number of patients with dyspepsia where GPs simply want to get an endoscopy in order to try to work out what's going on, but they also need a management plan. Could these things be moved into the community? Is there an opportunity here? And I think with a framework to build on, I think we can start to move towards that model, and I think it would be a hugely beneficial system. And the reason I think that there are benefits here are that it fosters communication between primary and secondary care. And I think that that communication and that integration is absolutely vital if we're going to rise to the challenges that COVID are presenting. There's also huge benefits from the GP. I love my role as a GP with an extended role, and there's lots of evidence actually that GPs who diversify into other areas have a greater resilience potentially, but also just enjoy their career potentially more. So there's a lot of important aspects here. And obviously, at the heart of it are patients, making sure that the right patients see the right person at the right time. We want to make sure that our secondary care colleagues are seeing those patients who really need to be seen. And we can help by supporting patients in the community who potentially don't need that level. So this is my final slide and my final moment, my take-home moments. This is an important specialty. It's been lacking any quality indicators and finance until very recently, so I think we should be, that's a bit of a red letter day for us in gastroenterology and general practice. But we're at a crossroads. What do we do? How are we going to rise to this challenge? I think we should build on good aspects, and I think we should seize the opportunity for innovation. Thank you.
Thanks, Charlie. Come and have a seat. Thank you very much. That was a fabulous overview, and actually it really gives you a sense that irrespective of the pandemic, there are opportunities for change, and the interface between primary and secondary care is actually a real opportunity right now in gastroenterology.